key representatives from many member states, standard development organization, academic and research institution, implementing partners, donors, and subject matter experts, in addition to WHO staff and experts concerned with the development.
5 minutes.
Thanks. I am Moacyr Perche from Brazil. I am General Coordinator of Project Management of Ministry of Health and in the Department of Informatics. I want to thank the opportunity to attend this meet and greet everyone in the person of Najib Shorbaji and bring greetings from Dr. Arthur Chioro, Minister of Health and the Director of DATASUS, Dr. Augusto Gadelha. To speak of our experiences, it's important to contextualize the Brazil scene in informatics and health. Brazil is the 5th largest country in the world with 200 million inhabitants, more than 90 million internet users, 140 million with unique national health card processed, meaning cleansed and deduplicated. Brazilians are among those who spend the largest amount of hours on the internet in the world. Yeah. Federal tax forms are available and only filled in an electronic way and via the internet. The national voting system is fully electronic. We have the results in 4 hours for 135 million voters. My country has taken 25 years ago the challenge of deploying the SUS, National Health System, trying to apply the equity of access, universality of care, and integrity of care. We believe in universal access. Health is a right of all. Approximately 160 million individuals rely on SUS, on the system unique for health. Full coverage, free of charge. Today, we have about 12,000 patients in home care and 100 million people under the care of family health teams, including all services and procedures. 1 million hospitalizations by month, the highest number of public organs transplants of the world, and 90% of the vaccine market is driven by this unique system. Yeah. Funding and management are shared across federal, state, and municipal levels. An effort orchestration about 5,587 managers who raises the complexity of this task. And regulated by our ANS, National Agency of Supplementary Health, we have private health plans for those willing to pay. Approximately 1,100 health plan organizations. Individuals cover about 40 million people. Policies for establishing standards, semantic and technical, ICD-10, ICD-11, SNOMED-CT, DICOM, AGL-7, OpenAir, started in 2011 after a year of discussion. With federal, state, and municipal levels, we have a portfolio of more than 140 systems with a high degree of fragmentation and compartmentalization of information systems, which are many and scattered. Authoritative enforcement are erratic, who raises energy and longevity in government decisions. Brazil has a long tradition of health information and informatization of controls and indicators, but little experience in informatization of procedures for the assistance and health management, the essential of e-health. And we approved in 2013 his national policies of information and informatization of health, task who involved over 100 people along the year and improvement in all instances of social control in the country. Since May 2012 has been DATASUS promoting a series of workshops on electronic health record systems for the system and the country, including the private services. An important political barrier was the gap of consensus on the concept of e-health, needed to leave the focus of the operation of the electronic health records for a strategic look. Other was the absence of the organized society into this discussion. We face problems implementing standards because there is a period of development of systems and the need for capacitation for both the health professional and the health informatics professional, just like other countries referred. Another important issue is the legal loophole created. Reality is faster than regulations, and these new forms of citizen interaction with the services require a bioethics discussion of these changes who has not yet been performed. One of the most important facilitators for the implementation policies of standards of health data at national and subnational was the document, the ITU method for a national health strategy. Several initiatives, academic, public and private, are being made in that direction and embrace the inspiration. ITU proposes a simple framework and didactic to facilitate this discussion. At this moment, we are discussing and disseminating the third review of this document, seeking the approval of the document in all instances of the system and tracing parallel tactical operations to ensure short-term results without derail this strategic vision. The governance of the policies to maintain the standards at the national level, which is a new activity for health, despite aggregating with other areas of government, such as industry, trade, banking sector, is one of the most important things to concentrate now. It's a priority to establish short-term results in the field that give visibility to the efforts and concreteness to the concepts of health. Parallel to the discussion of the policies, we act. For example, we still have a large amount of cities that are integrated in a manual way and without international standards to national base of identity. Recently, we did the integration of base records from the National Health Card in the city of São Paulo with 15 million records cleansed and duplicated. In parallel, we are developing the deployment of PIX-PDQ and MPI standards. We already have published 4 services for internal applications of the National Health Card and bus service and adapting existing applications to interoperate with the standards. And recently, we engaged the IAGE initiative. Our national databases to identify professionals and institutions providing health care are being migrated to the bus service and will soon be interoperating with internal applications. We have a semantic framework developed with the identified services and models approved demographic information and 2 clinical models to implement. The summary of attendance in primary care and hospital discharge summary of the patients. The citizen can now consult their health records regarding the use of health services and professionals who attended and soon these clinical contents of your health record. The government, private sector, and civil society has a key role as facilitators to compliance with the policies of standardization, participating to this discussion on the several levels of social control of our national health system, transforming a government policy in a state policy. We are glad to share this experience with you and learn with your experience. Especially thanks for the support of PAHO in this job with Nando Campanella and Dave Novillo.
Thank you.
Thanks.
Thank you. May I ask my colleague, Mr. David Novillo, to sort of say a few things on how they approach support to e-health and its standardization in the region. David.
Thank you, Najib. Ladies and gentlemen and colleagues connected through WebEx. Through the region of Americas, interesting experiences are to be found in countries such as Argentina, Barbados, Brazil, Canada, Chile, Colombia, Mexico, Uruguay, and the United States. There are 4 main actors in implementing standards at the national and international levels: hospitals, institutional initiative by medical and academic centers, telemedicine networks, and universities. Although calculations indicate that 30% of health-related expenditure is devoted to managing information, and it is estimated that a completely interoperable national health system could save a net 5% of total spending, it seems that a great deal of work remains to be done. Lack of governmental coordination and digital agendas constitute one of the most important barriers in the area of standards and interoperability. There are specific problems in the region of the Americas that result in people lacking adequate health coverage. There is no doubt that interoperability is an equalizing factor in this regard, since it facilitates sharing information which helps to partially close the access gap. In this context, there are 4 elements that need special attention in the area of standards and interoperability, namely resource and infrastructure. The region of America suffers from major disparities in this regard. For example, 50% of people have access to computers in Uruguay compared to 10% in El Salvador. The region must strengthen its infrastructure to achieve the sharing of information among different health organizations and across geographical borders. Reliable networks, internet access, and availability of electric power are among the components needed. In addition to resources and infrastructure, there is a need for policies that provide a legal framework and support the implementation of e-health standards, as well as providing protection in the area of intellectual property rights and security and privacy of information. Chile and Uruguay are 2 examples of countries that are relevant in this respect. Legal and ethical considerations are also key. It should be possible for different entities to share sensitive information under conditions that ensure privacy, high levels of security, control access, and user identification. In addition to all of the above, properly trained human resources are needed. It is important to work on standardizing learner objectives, competencies, the required curricula, and the roles of health workers in the different countries. In addition to training medical workers, other staff should be trained in e-health policy, development and planning, communication and leadership. Finally, and not less importantly, the participation of international standards associations is essential in order for standards to be designed in accordance with national needs. In the case of the regional office in the Americas, the Pan American Health Organization, we have a regional strategy and plan of action on e-health, the resolution CD51/13, that was approved in 2011 by the member states of the Americas, whose priorities include developing national e-health policies and sharing their experience with each other. In addition to this mandate, PAHO has just approved this strategic plan 2014 to 2019, and it is great honor to be able to share with you that one of priority objectives is to support the countries in establishing national e-health strategies. We are convinced that establishing national policies is the foundation for advancing in an orderly and efficient way on standards and interoperability. I believe it should also be added that is based on the conclusion of the regional technical consultation on e-health data standards and interoperability held in Peru in April 2013 with national officials of Barbados, Chile, Colombia, Costa Rica, Jamaica, Mexico and Peru. And finally, after to be here during these 2 days, I think that we have to put focus on three things. First, we need to communicate better our achievement. Also, we need to finish our handbook that is also ready, and we need to work together and have an evidence report which can show the benefits of the investment in standards and interoperability for the decision makers. Thank you so much.